Welcome to Health Hour, a session for you by Black doctors, hosted by the Caribbean and African Health Network. Ever sat in a doctor's office thinking, they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m., this is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Okay, good morning, everybody, and welcome to the latest edition of the Caribbean African Health Network Health Hour. Today it's quite an exciting topic, quite close to my heart. So let's do some introductions first. So my name is Dr. Kwasi Appiah. I'm a dermatology registrar based in London and Manchester, and today we've got an excellent speaker in Dr. Kwasi Appiah. Dr. Kwasi Appiah is a GP with an extended interest or a remit in dermatology, who works predominantly in the community with it in Essex, but has experience both in secondary care and hospitals as well as community care as well. With a 15-year history of working with dermatology in the community, he has not only the experience, but also the knowledge and the social intelligence that helps us appreciate how patients initially presented to health services with dermatological conditions, and really how to connect and address some of the anxieties that you have today. So before we start, good morning to you who are based in the UK, and those of you watching online, on YouTube, on Zoom, and those of you who are international, because we have a wide range of network. And I'm looking forward to the questions that you may have at the end of the session. So here's some house rules. Remember, the group chat is open, so please comment, please ask questions, and anything. There's no stupid question. That's the main thing. It's a safe space for you to ask questions, get some advice, get some direction to help you with your own skin health issues. Remember, because we don't see you, can't give you direct medical advice, but at least we can guide you in the right direction. So without further ado, Dr. Kwasi, I'll let you start sharing your screen, and we can start. Let me know when you're ready. Perfect.
Okay, so can you see my screen?
Yep, we're good to go.
Fantastic. Okay, thank you, Chinedu, and it's good to meet again. And I know we both share a passion in dermatology, as you are a dermatology registrar training to become consultants very soon. So as Chinedu said, Kwasi Appiah. I'm a GP with extended role in dermatology, and I work in the community in Essex, and then also as a GP in Hertfordshire, and I've been doing this for about 15 years now. Really, today's topic is really close to most people's heart in terms of skin. I have no conflicts of interest, so a lot of things I can talk about is about products and other things, which is just beneficial in general to anyone. Obviously, the kind of things that I wanted us to think about, focus today, is the issues with race versus ethnicity versus skin type, the challenges that UK medical practitioners and doctors face on skin conditions. And then we'll talk about a few common skin conditions in adult children and also Black women, which in Black skin. And then there are some of other things I will consider about cultural practices, which can lead to some dermatological challenges, risk of health health in misdiagnosis, and then forms of treatment briefly. Obviously, this is general public, so I'm not going to go much into details in treatment, but we'll talk about the things that will be beneficial to everybody to understand in layman's terms. So when it comes to race, ethnicity, and skin type, there is always a difficulty to think about how we put it. Race is a geographical distinction. It could be, you could say people are called Caucasian or Australioid, or it can be people from Mongolia area or people from Africa or Asia. So there are a lot of different things that we can ascribe to race. When it comes to ethnicity, is basically based on origin and phenotypical pigmentation. So the spectra is wide, and when we look at what we call the Fitzpatrick scale, which was traditionally introduced by an American dermatologist in 1957, how to distinguish on skin type based on the response to UV light. That's what most dermatologists will use to try and describe skin type. So when in dermatology, when we say skin of color, usually it will be pertaining to skin types 4, 5, and 6. Skin type 4, 5, and 6, which is the darker or heavily pigmented skin type. And as you know, most people who describe themselves as black might fall within this range, might not necessarily be a type 4, a type 5, or type 6. So there is a whole range of how we describe ourselves. And so the skin type and Fitzpatrick scale is not always the perfect way to describe ourselves, but it's the best thing we have now. So in general, in dermatology, we say skin of color will be skin type 4, 5, and 6, as we use to help us to make decisions and in managing skin conditions. Right. So let me try and see if I can move from here. So the changing demographics in UK, this was research from publishers in Office of National Statistics years ago, where it shows that the UK demographics is changing, and it's estimated that by the year 2051, the non-white population in the UK will be projected to increase to about 21%. And the white population will fall to about 79%. So this is skin color, and not necessarily ethnicity and race. As we've said before, there is a whole diversity of this. There is also a mixed race population is predicted to raise to about 249%. So there is an importance for medical professionals to understand how people and the skin type they treat affects their decision making, and so this has been very challenging for UK medical practitioners, and because the training had some gaps, and we remember during the pandemic, this young a medical student at St. George's then wrote this book, which became famous, called Mind the Gap, which it talks about some clinical signs which they find in medical school difficult to teach around people on heavily pigmented skin type, or skin types 4, 5, and 6, Black, Asian, Afro-Caribbean in particular, because these skin types have a different or peculiar pattern of reactivity or presentation and challenges. Most of us in medical school, I did medical school in East London, in Queen Mary, and though we had a mixed population there, we were introduced to a lot of mixed cultures and different pathology and East London. But we only spent 2 weeks training in dermatology, and I don't think it's different from any other medical school as well. So when you see your average GP, they might not have spent a lot of time in dermatology, even though the skin is the largest organ in the body. And then predominantly all the textbooks in dermatology that we have trained with and we use in our training have predominantly Caucasian skin types. Until recently, there's been a greater awareness in the last couple of years. And, Chinedu and myself has been part of this skin of color training UK days, and now skin of color or training for heavily or darkly pigmented skin has been incorporated in training dermatologists in this country now, so which is really good. And this was not until 2021. So there is a good understanding that there was a gap in training. It has been acknowledged. There are a lot of ways to address that with curriculum changes, and even training doctors and dermatologists are becoming more aware now. But it's going to take time. It just take time. So we'll still face the challenges as we do that. So what's the difference? The difference is that physiologically there is no difference in when you look at the skin. There's no difference in kind of the number between the skin cells which produce melanin, which is the pigmentation unit apparatus in the skin. But usually, what it is that the distribution is produced larger in black skin, and also in black skin, the top layer is more produced with melanin. So this is the surface of the skin. This is a darker skin, and this is a lighter skin. So the cells that produce the unit area of the cells are the same, but is the production of the melanin, which is the dark black spots that you can see, which is genetically determined by your race. So if you're black and you have parentage, that's what determine how much melanin you produce. And so it's highly pigmented on the surface more, and whereas in white skin the pigmentation will be at the lower surface of the skin layer. This is just the layer of the skin, and that has an effect on the way some conditions present. I don't know if you can see. So what it shows is that because of that, there is a different way in which these differences and the depth affects the way skin conditions manifest themselves. And dermatology is also not about just skin. Dermatology is also about hair. And as we know, hair in black people is different for hair in white people. You have a lot more helical hair, spiral shaft. You do get a lot of ingrowing hairs as well. And also, even though there is no difference between the fat layer underneath the skin among the various races, when there is sun exposure, what happens is that the elasticity of white skin suffers greatly, because of the effect of sun damage. So we used to say that black don't crack, which means that we don't age that much. But it's not always true. And yes, there is a bit of protection because of the thickness of the skin in black skin. So we do get a bit of photo protection, and evolution has helped us, and genetically that's been a protective factor. The other thing that a lot of doctors also struggle is when we are in medical school, we are taught about how to appreciate inflammation. So when there is inflammation, we are taught is redness, and redness is not easily appreciated in darker skin. So a lot of black skin issue would be much more of hyperpigmentation or deep pigmentation, or even in lightening of the skin. And also there is what we call the follicular changes, where the skin changes becomes more rough and sandpaper like, rather than scales that you see on white skin. And also when you rub and you scratch your skin a lot more, it has a different impact on black skin compared to other skin as well. So I'm going to show you some normal variation of some skin conditions which are quite common. you see it a lot in black skin, and they are not necessarily pathological or diseases. They are just different variation because of skin type. So this is a condition called idiopathic guttate hypomelanosis. Idiopathic because we don't understand what causes it. We think there might be some related. Guttate means like teardrops or raindrop or really scattered. And hypomelanosis is depigmentation or loss of the pigment. So you get these white patches on the skin. This patient has got that as well. They've also got this DPN, dermatosis papulosis nigra, which are also these brown patches, lesions that you can see on the skin as well, which is another thing which is very common in black skin. And this is on this a leg of a similar patient as well, these white patches. So this is normal. It's not pathological as opposed to because people see this and they start worrying about this condition, vitiligo, which is a different type of skin condition, which is more or less an immune type of skin condition where your body's melanin producing cells attack each other, and therefore you get depigmentation. So the areas are affected in your hands or your face or other part of your body where you are not be able to produce pigments because of your immune response. So that's the difference. So some people, you get referred by people who have the previous condition, which is idiopathic guttate hypomelanosis, worried about vitiligo. The other conditions, a few conditions that we'll talk about, which are normal or common. I'm going to, sorry, my slide is, yeah, go on. Yeah. My internet might be a bit slow, so my slides can't keep freezing. This is melaninikia, which is benign pigmented lesions on or pigments on the nails, and these are on longitudinal ridges of the nails. Now, this is ethnically determined, so this is quite common. But we worry about melanoma or skin cancer in the nails, on the nail bed. But a lot of patients will have all these brown longitudinal lines on the nails, which is not necessarily melanoma. But you have to, you see that you have multiple of them. This one in particular has multiple pigmented lines in both hands, and these are benign and they are not melanoma. But the reason is that the awareness has to be there because you can still get melanoma in black skin, and the difference is in melanoma you can see there's a difference in the way that the ridges or the black lines look. In this one you can see that it tapers towards the edge, and is wider at the base, and it kind of, you can see the pigments over the nail bed as well. This is another typical one. So it's a bit different, like the same, this one, it tapers towards the edge and is wider at the base, and that's kind of something that gives away. Whereas with the ones which is ratio determined is parallel and is uniform in line. So those are quite reassuring. But obviously, if you see black lines on your nails and you're not sure, you can get your doctor to get check that to reassure you. I talked about DPN in the first slide that we had with a patient with guttate hypomelanosis. This one is very common, in Afro-Caribbean. Morgan Freeman's picture is here, and it's dermatosis papulosa nigra, which, or DPN as we call it. It's a variant of something we call seborrheic keratosis, and very common in black skin. It's purely benign, and it becomes much more of a cosmetic nuisance. So most treatments, you will not get any treatment on NHS for this, but people in the private sector might be able to help you out to treat some of these conditions. I'll look at a few skin changes that Black women will experience during pregnancy. This is a condition called melasma, which is not only just in pregnancy, but people on contraceptive pills or estrogen containing products like HRT and stuff can get these dark patches on the cheeks and the forehead, and usually it spares the corners of of the nasolabial folds area, and mostly on the cheeks, and also might be on the foreheads as well. These are quite common, and obviously one of the things that is important for these things is sun protection does help. And there are some over-the-counter creams and products that can be bought to try on these treatments, or for anti-pigment creams, which I can discuss with you when we come to some treatment. Obviously, if you struggle with it, you can get to your doctor to refer. There are some treatments and some tablets and other things we use in dermatology in treating this as well. This is another physiological change in pregnancy. This is striatum gravidarum, where you get stretch marks, and in black skin or heavily pigmented skin, they become darker. So that's one of the features. In black skin, things become darker when there is a bit of inflammation, or it can become scalier or thicker with a bit of inflammation, and this stretch marks becomes darker in pregnancy. Most moles or skin lesions become darker because the precursor of this pregnancy hormone has a similar route as a precursor of the melanin producing cells in the body as well. Hence the pigmentation and changes that you see with pregnancy. Again, this is a linear graph. This is a darker marks where you get on pregnancy over the bump. I've already talked about nails, melanonychia, which is the pigmentation of the nail, longitudinal nail lines which is normal variant in black skin, but they become a little bit darker in pregnancy for the same reason I've mentioned. Sometimes the nail also begin to become a little bit loose, or we call necrolysis. Sometimes this might be due to iron deficiency in pregnancy as well. It might be purely physiological, but that needs to be checked out in case that becomes a problem and becomes a little bit brittle during the pregnancy stage. A lot of pregnant women will talk about hair changes. This is a condition called telogen effluvium, where you kind of lose the natural shedding of hair. There is a hair goes through a hair cycle, and there is the stage in the hair cycle where you tend to lose a lot more hair, and it can becomes a bit exaggerated during pregnancy and during post-delivery, even after birth, childbirth. There can be a lot more of hair shedding when you comb or when you brush your hair. And also hirsutism, which is abnormal hair distribution, and this mostly might be due to male sex hormone. Particularly sometimes might be in women who have maybe pregnant with boys, or it's just mostly what we call hyperandrogenism. Is a response to circulatory male sex hormone, which gives you the distribution of hair which men would normally get, which is not desirable for women, having hair on the chin and a mustache hair, etc. Okay, so those are some physiological changes that can happen, but it can also have some pregnancy specific changes. A lot of itching in pregnancy. You can get jaundice in pregnancy. This is a woman with jaundice. You can see the yellowness around the hair. The skin changes, becomes a little bit yellow, and this is because of what we call cholestasis, where the liver becomes blocked, and you get high levels of bilirubin in the system, and it can be related to pregnancy. This is an emergency. Usually you need to see obstetrician. They'll keep an eye on you, but this can be a case of jaundice in pregnancy. It can happen even after delivery. There is another very I won't say common, but very itchy skin condition in pregnancy. You can get that in either the second or third trimester, where you get this itchy, what we call pruritic, which means itchy, urticated, which is raised areas of papules or bumps or plaques or raised areas, which you get in pregnancy. We call them PUP for short, and this can be like hives like condition, might be related to the pregnancy hormone. Most of the time, this can be very incredibly itchy. A lot of these patients will need topical steroids on the skin to reduce the itching. This usually resolve after pregnancy. Antihistamine can be very useful in this, and sometimes even 4 times the usual dose of normal non-sedating antihistamine can help, so far as it's not contraindicated in pregnancy. So that can be helped, but most of the time this resolved after delivery. But I've seen some which is protracted up to a couple of weeks or even a month or two after delivery, and still can be challenging to manage. But this is related to pregnancy as well. There is an autoimmune condition which we call pemphigoid gestationis, which is kind of a blistering skin condition that you can get, where you get a lot of blisters on the arms or even on the pregnancy bump, which is an immune system condition that causes pemphigoid, where you get separation of the second layer or basement layer of the skin, and you get a lot of these blisters. So this is another condition where you need when you see this, it needs to be seen by a specialist, and it can be treated well with steroids and respond to steroids even in pregnancy. So apart from these conditions which come in pregnancy, there are other normal skin conditions which can either worsen during pregnancy. So people with acne can sometimes worsen during early pregnancy. People with eczema or atopic eczema or psoriasis, and even, as I mentioned, the melasma, which is the pigmentation on the face, can get worse. Periorofacial dermatitis, which is eczema rashes around the face, can also worsen. Psoriasis can sometimes improve. Rosacea, it can get also worsened during pregnancy. And then during pregnancy, you tend to get a lot more maybe skin tags because of the rubbing. And then people with systemic lupus skin types and hand eczema, either the pemphigoid or the blistering hand eczema types, dermatitis, can also worsen during pregnancy. So these are pre-existing conditions that people have, and when they get pregnant, sometimes it can worsen. There are a few conditions that might improve. Some people have noticed their acne improve late pregnancy. Some people have also noticed that their eczema actually improve. Now, a very debilitating condition, hidradenitis suppurativa, which can also affect a lot of Black patients, which involves recurrent boils, multiple boils in the groin, in the armpits, under the stomach folds, in the around the buttocks area. It can be a very, very difficult condition. So if you have this is not just one boil here and there. This is recurrent, deep boils in the what we call the apocrine sweat glands in this area, which can become very, very painful, can discharge a lot of pus, and it can be very debilitating. So this condition can improve in pregnancy. I've seen that in patients which actually went away in pregnancy, and after they've had their baby, it came back as well. But that's another condition that we see a lot in dermatology, and disproportionately affects a lot more Black patients. Psoriasis, as I said earlier, may worsen, may improve, or might even stay the same during pregnancy. So those were just a few things that talked about in pregnancy. Now I'm just going to quickly go through a few other common skin conditions in children and adults and how they look on Black skin. So this is chickenpox, and I'm sure everyone who's a child will know what chickenpox looks like on your child. You get these tiny fluid-filled blisters, very itchy, and the issue with Black skin is even when we treat the blisters, when they dry out, we're left with a lot of post-inflammatory pigmentation. It's the scarring that can be a big problem, and it's not just with chickenpox. It's with most any skin conditions on Black skin. Is the scarring that can be challenging. Now, this is a child with eczema on the face. And this is eczema, which usually when the baby starts, it might be on the face, and it's a bit different from the white skin. This will become more thick, or what we call lichenified, particularly in the back of the hands of this boy. From a lot of scratching, it becomes scaly. You don't see the redness which you see in white skin, but it's the scaliness, and shows that it's actually inflamed eczema. And unfortunately, this presentation is not appreciated by a clinician who is not used to seeing black skin, and might undertreat it. And that's the challenge that we want to highlight to most clinicians in some of our skin of color training, and all the DIS training, dermatology skin of color training, and why it's been incorporated in the syllabus, so that we don't undertreat black skin. This is eczema in a hand crease, which has a bumpy rough pattern, which we call a follicular appearance on the eczema. And this is a typical presentation will be on black skin. This one with a lot of rubbing or lichenification. This is really inflamed eczema. It gets darker. So that the severity in black skin means that the eczema can become a little bit darker. And because it doesn't look like the typical redness, sometimes the doctor cannot appreciate that severity and undertreat them, or even give them a weaker potent steroid, which usually do not clear these ones. And I would say that you treat them properly with a much more potent steroid, and then you can wean down. So under treatment is a big issue on black skin. So when your child's eczema becomes a little bit bumpy and thick and scaly like this, it shows that it's becoming a little bit more severe, and therefore it needs to be treated. This is another condition that can be visible on black skin, which it looks like a chicken skin. We call it keratosis pilaris. Really, when you feel it, it might be a variant of follicular eczema. That's what we think. And again, you treat it the same way with a lot of emollients or creams that has a bit of urea in it. They do help. Sometimes slight ingredients of a bit of salicylic acid, some combination of creams do help smoothen it a little bit more. If it becomes itchy, steroids can help as well. So that's one thing, just to bear that in mind. So this is known as keratosis pilaris. This is eczema on the face of a patient, what we call follicular perioral dermatitis or perioral eczema, which has this bumpy appearance against these bumpy appearance or follicular appearance on there, and it's not very red, but you can see that this is also inflamed, and it has to be treated properly. And most of the time on the face, we can use non-steroid creams, or creams, something called like calcinuric inhibitors. We call them protopics or Elidol. They can respond really well. In fact, they are quite good in black skin, because sometimes we worry about steroid, because steroids can cause skin loss or pigmentation loss. But if eczema is really bad, you need steroid, and then when you wean off, you can move to these non-steroid creams, so that you avoid all those concerns that we have with steroids and skin thinning and other things. So in black skin, sometimes if people are worried about pigmentary changes and they want to avoid steroids, you've got the protopics or Elidol, which are different creams which are not steroids and safe to be used on sensitive areas where people are worried about steroids. Steroid phobia has become a big thing these days from social media. Again, this is eczema, which is from excessive scratching on the black skin. It becomes very leathery and itchy, and this kind of can be a challenge for treatments as well. Now, with eczema, there is a lot of stuff over there. There's a lot of creams on the shelf. And most people would have gone to the pharmacies and they don't know which one to buy. So creams comes in various vehicles, or emollients comes in various vehicles, and it can be a cream, which is usually soft. It can be a lotion, which is very watery, dries up quickly. It can be ointment, like these ones which are greasy and feels like Vaseline, or it can be gels, and sometimes it can be sprays as well. What is the best cream? The best cream, I say to my patients, is the best cream is the one that you like. The best cream is the one that you use. The best cream is the one that you feel works for you. So there's nothing like the best cream. If you want to, if you're not going to use it, it's not good for you. So a lot of patients, you prescribe creams for them, they use it and they don't like it, and then it goes to waste. So buy what you like. Any in eczema and dry skin and psoriasis and all these dry skin conditions, use the creams that you like. If it's a cream, if it's an ointment, if it's a gel, what you like is the best cream. And then when you are treating steroids, eczema, we use steroids, and the steroids have various strengths. So some of them might be hydrocortisone, the weakest steroids. You can even buy that over the counter. There are some of the steroids will have a combination of steroid with antibiotics, like the bottom one here, Fucibet. Some of them will be steroid for eczema on the scalp or psoriasis on the scalp. We've got Betnovate here. And some of the steroids are stronger, like mometasone is a little bit stronger, or Elocone is a little bit stronger than the hydrocortisone. So they're very strong. We have what we call a steroid ladder. So the weaker the steroid, the less effective it is, but the more you use it on sensitive areas. So sometimes when in black skin, because the skin is tougher and thicker, and there is a lot of lichenification during or thickening of the skin with eczema, sometimes you need to be treated with a much stronger, a potent steroid initially, to get it down before a weak one to use. So it's no use. Most, your eczema is being prescribed hydrocortisone. You keep on using and using and using, nothing happens. So it's most doctors will say, look, you need to treat it properly first, hit it hard before you wean down. And this is the worry that we have, because sometimes we think that steroids can cause depigmentation, but sometimes it's actually the condition itself that causes the pigmentation changes. The eczema itself can cause pigmentary changes, not necessarily always the steroid. But the steroids you do, in that case, you can use non-steroid creams like Protopic. Ringworm is an infection, a fungal infection, which is very, very common in Afro-Caribbean boys and children. And yes, we always say it's not, you don't always blame the baba. It's not always the baba. Sometimes it is, but it's not always. This is ringworm on the face. This is ringworm on the scalp. And if it's not treated properly, you can get what we call scarring, alopecia, or that area gets scarring, or develop this pussy area, which we call carrion, which is an infection of inflammation as a result of prolonged ringworm or tinea infection. Most of the time, this needs oral antifungal treatment and not creams. And a lot of the time, most unexperienced GPs, or who have not GPs will not be exposed to a lot of these, will give you creams and they don't work. So sometimes you use like an oral terbinafine antifungal tablet for about 4 weeks, or something like itraconazole, something like that for 4 weeks, and then you can use antifungal shampoo like the Nisro shampoo, but also don't treat the boys alone, treat the siblings, everybody else in the house. That's because this is highly contagious. So if you treat the tablet with that, then you can give the shampoo to other siblings and make sure they are not sharing comb and other things at home. That is another yeast infection, which is very common on black skin, called psoriasis vesicola. Again, it has this scaly appearance, and it's mostly when you sweat during the summertime. People go on holiday, it's worse, and it's quite common in black skin. Again, you can use antifungal shampoos, and if it's not responding, you can be prescribed tablets for that. Acne of various type, excessive greasy production or sebum production, could be hormonal induced, and you can get all these black areas of post-inflammatory changes from where the acne has gone, and that is the biggest thing on black skin. acne can be even from pomade use, excessive greasing of the hair. Pomade can cause acne. It can be from occupational hazard, from wearing things that can trigger acne production. Things like steroid, some tablets can also even induce acne. So it's important to use UV protection, so sun protection, so to prevent hyperpigmentation if you're treating acne. There's very little evidence about our diets, because most people ask you, doctor, what can I eat so that my acne does not get worse? Yes, low glycemic or index food can help, but it's a bit anecdotal. There's not a lot of evidence in there, but any good thing, good healthy diet without not very strong sugar can help as well. But the challenge with acne is the post-inflammatory pigmentation, and I'll put this picture here in that, it's not just with acne. Any skin condition or black skin is a post-inflammatory pigmentation that affects us. And these stuff you can buy them over the counter. Pigmenum you can't, because it's the most effective treatment with the triple therapy with the hydroquinone, hydrocortisone, and retinoid. But you can't get that over the counter. You need a prescription, and even is restricted in certain areas in prescription from dermatologists, even in a hospital, and is red listed, but you can get them privately. But all the La Roche-Posay and all the Eucerin stuff, you can buy them. And Boots, you can go any of those big supermarket pharmaceuticals where these anti-pigment stuff are quite good. There are day creams, there are night creams, and they can help. And this Mela B as well is another good one as well. So, but as I was to say also, sun protection is really important. So this one has already got SPF factor 30 in it. And this one, you have to use another extra SPF factor 30. So hyperpigmentation, either from acne, from eczema, from psoriasis, from any skin condition in black skin, you can treat them with any of these anti-pigment cream products. So cultural practices that really affect us. Right, this Epiderm cream. I saw this in one of my local Afro-Caribbean shop. It actually has got the similar ingredients as you have in Pigmenum, the one I showed you from hyperpigmentation. It's actually got hydroquinone, hydrocortisone, and it's got and retinoid in it, and people use this in bleaching the skin. And these can also lead to acne. You can go acne, steroid-induced acne, and all these keloids agents. Most of them have steroids in it, and so you can get all the side effects of steroids and skin changes like you see in this picture depicted there. And also something called exogenous ochronosis from which changes the skin color to slate skin because of the hydroquinone used in those products as well. So just be very, very careful the products you use from cosmetics. And I talked about pomade acne. When you grease, you save your children from after they're plaited so much, you can lead to acne, which is induced by the greasing of the hair from plaiting. Traction alopecia, the women know so much about this, and you can see that a lot of tight ponytails, etc. You lose the hair, and then you get the fringe hair on these edges here, and a lot of the plaiting braids and stuff like that can lead to traction alopecia. You get all these fringe hair, and really can be challenging unless you change the practices. Otherwise, you can lose hair, and it can lead to non-scarring alopecia. This is a condition which, in fact, I saw this a week ago in a Nigerian woman who came to see me in clinic, and she had a receding of hair. She was actually referred by her GP that her eyebrow has become lighter. And that was the reason for the referral. And as I was examining here, I could see that there is a receding of the frontal hairline. There is complete loss of, so this is not her picture, there's a complete loss of her eyebrow, and that's why it's become lighter. And it's actually a frontal fibrosis and alopecia, which kind of a lupus type scarring alopecia condition. And when it reaches this stage, sometimes you need to be in the hospital, secondary care. You need tablets like hydroquinone, steroid injections can help, and a lot of immunosuppressants. So she was said, no, I'm not interested in that. She was happy to just make up and that would do. But that's the key. When you start losing this frontal hair, that can be challenging to reverse. And you get other conditions like in men, you get a lot of pseudofolliculitis. So our cultural practices, we like to clean shave, we get our razor bumps. It can get infected and it can get scarring. And we say the ingrowing hair cause a lot of inflammation and it becomes challenging. Sometimes I advise using antiseptic wash like this Hibis Scrub or Dermo. You can buy this over the counter when after shaving or when shaving, and just to prevent the inflammation and infection. But when it becomes inflamed, you might need some steroids or some antibiotics to help clear it. So the worst case scenario is can develop into keloidal acne at the back of the hair. This is close shaving, a lot of friction, and it can be really, really difficult to treat this. We can do steroids, we can use topical potent steroids, Dermovate, and other things, and sometimes even steroid injections can be what we can resort to. So it's usually typical in black men, and it's not always the barber's fault. It's just that we, as I said, we scar easily, we develop keloids easily. So a lot of friction from small cuts from the shaving can constantly develop these folliculitis, which can become keloidal and become difficult to reverse.
Dr. Kwasi, sorry, we've probably got 1 more minute left before we
Yeah,
need to.
that's fine. I've already got about 3 or 4 more slides. So these are another few conditions for folliculitis decalvans, as another condition there. And then there's another scalp condition, which is very, very common in middle-aged women, central centrifugal alopecia in black women, very, very common. And then, these things needs to be addressed. When you see it, you're losing your hair and you need to get referred quickly. And finally, we always worried about keloids. Keloids, a lot of black people develop a lot of keloids easily because our fibroblast activity is very active, and therefore either trauma or injury or piercing can develop keloids. So it can be either treated with topicals, strong steroids, injection of steroids. Some people use liquid nitrogen. You can try silicone scar stuff over the counter, but otherwise it can be challenging as well. So this is there is a lot to do on black skin. I've kind of run through so many things. I think it's better more to ask questions, some areas, so that sorry, I had to go on because you can't do this thing very short. All right.
No, that's amazing. Thank you so much. That was comprehensive. So good. So good. So in the interest of time, I think there's quite a few questions. We'll try and run through a few of them, and where we can't answer them today, we'll try and answer them at another session as well. So thank you again, Dr. Kwasi. That was incredible. So I'll start off with the first question we have is, please advise on the use of sunscreen in type 4 to type 6 skin types.
Yeah. So sunscreens have big role. Okay. So the biggest role and the biggest importance of sunscreen is hyperpigmentation, post-inflammatory hyperpigmentation. It's not the use for skin cancer, as in white skin. Okay, so it protects us from burning, and the burning of the sun, UV sun, causes the post-inflammatory pigmentation. So conditions that I talked about, melasma, even from acne, for anything. So the importance of sunscreen is not for skin cancer, but mostly for post-inflammatory hyperpigmentation.
Okay, amazing, thank you. Okay. So I guess the next question is, how do common conditions get severe, like acne, psoriasis, and dermatitis, uniquely affect black skin and hair follicles? It's not quite a clear question, but I think the question is there a difference in the severity that we see in like the common dermatological conditions in the
Black
I guess
skin.
in
Yeah.
black population
I,
compared
I
to
think
European
the question of severity is the appreciation from the clinician initially when they diagnose us, and that's our issue. So what's because the appearance is different, they cannot be appreciated that it's severe. So eczema might be thickened and lichenified and look like the scaly or the follicular in appearance, and it
population.
can be dismissed as mild when it's actually showing severity for it to be treated properly. So it's not severe. It's the appreciation about the clinician who's seeing it in the first time of diagnosis. We're getting it right at the first time. Yeah.
Amazing, thank you. Does diet, stress, and environment affect our skin? Do I need one of those skin lights in my home?
No, don't get any skin light. So, yes. So, look, our skin is the largest organ that we have. Okay.
Mm,
So, a good healthy diet is really important for our skin. It will manifest on the skin if you eat junk. So that's the simplest thing because it's the largest organ. You can't get away with it, and it's the first thing that everybody sees. So it doesn't necessarily means that a lot of conditions are caused by diet, but it contributes to either its severity and its treatment and management. So yeah,
okay, and I think that goes same for stress and environment because
yeah,
the skin is affected by everything as well.
everything. Yeah, absolutely.
So the next question is quite similar to the last one, but does living in the UK, Europe, weather due to the weather, cold, low sunlight affect black skin differently? And
Does it
when
work?
does living in the UK slash Europe, due
Mhm.
to the weather, the coldness, and the low sun, affect black skin differently?
I think it's so not necessarily. Obviously, there are certain environmental things that can affect skin. That the sun exposure. I mean, we don't see a lot of sun in the UK, but so then issues of hyperpigmentation becomes we trivialize it, but we need to still use sun protection whenever during the summer month when you have conditions you're treating. Um, well, it's dry, so over the winter months, a lot of people will put on central heating in their house, and therefore, their house will be dry, so the skin get dry. So dry skin, the total body water loss is higher in in black skin. So in that sense, you need to use more moisturizer and
Mm.
to moisturize your skin. And or my son would say, I don't want to be ashy. So it's really is a way that we look at it. The environments, the temperature. You have to look after your skin. It's not necessarily the whole climate per se, but it's what particular environment you are in. Yeah.
Okay, great, thank you. Um, so following from that, when eczema has been treated
Mhm.
and is no longer active in black skin, how does the appearance change? How do I know it's better?
So when you know it's better, you know it's not itchy anymore. Um, the skin might be smoother, and which means it's treated, it's not thicker and it's not itchy. So the signs of inflammation in black skin will be thickening skin and itchy and bumpiness. So that means it's smooth. Then what you when that is done after you've treated it with the steroids, what you don't stop doing is the moisturizing. The moisturizing is a regular bread
Mm,
and butter every day, whether the eczema is on or not.
mm,
And so that's it. So, but if it's not itchy and if it's not bumpy and if it's not thick, it means that it's not inflamed at yet. But it doesn't mean the eczema is gone completely.
mm.
Yeah, it goes in remission. It doesn't mean it's gone. So that's the thing. You think, it's gone. I'll stop using my cream. I'm fine. Yeah.
Yeah, okay, cool. So I think you might have touched upon this one already, but I started getting moles as I get older. Why is that? I wonder whether they mean DPN rather than moles.
Yeah, this is the thing, isn't it? Yes.
Yeah.
So what's Chidi's mentioned I showed you the picture of the Morgan Freeman black lesions, more what we call DPN, and they are all seborrheic keratosis, which is a variant of DPN is a variant of seborrheic keratosis. They are normal proliferation on the skin. They are not moles. And so it's common with aging skin, all races. Black skin manifests itself in those tiny ones, DPN, more than other skin. But if you see your our Caucasian friends, they also have a lot of seborrheic keratosis, and so they also call it moles, but they are all not moles as well.
Okay,
But yeah, it gets
great.
more with old age.
Amazing. Okay, great. Thank you. Is hair replacement safe for black people?
Hair, what do you mean hair transplants?
I presume so. Yeah, I
Yeah,
guess so. Yeah.
yeah. Well, it depends. It depends on what you think. What is safe? It's a cosmetic procedure. They harvest follicle and then they implant stuff there. It's safe. It's also dependent on the hands of the operator and whether you trust them and their resources and what they have. Yes, a lot of black hair specialists or trichologists are there. And so yeah, if you trust the person, that's fine. I always one of my patients always ask me this question, and they look at my face and they see how bold I am, and they asking me why am I that done anything as a dermatologist. That tells you the answer.
Fine, thank you. Okay, so a few more. Um, Fine, okay. So if black skin is more prone to keloids, scarring, etc., what are we doing to provide our own cosmetic ointments and potions?
Right. So this the keloid and scarring is about the fibroblast activity. Fibroblast is the cells in the body that helps wound to heal naturally. And their activities seems to be a bit more overactive in black skin, hence leading to more scarring. So I don't think it's an issue of cosmetic and potions and lotions that we use. This is an internal thing and it's a genetic thing, and it's not even just black skin only. There is also skin of color general. Mostly, you can get a lot of Asians also get keloid. So, and you don't get keloid exclusively on black skin. So it's not straightforward as we think that we can just get portions and that it's much more complicated than that.
Okay,
Trauma,
thank you.
keloids is not just yeah, it's trauma can lead to a lot of
Yeah,
keloids. Yeah.
exactly. And so some more questions on HS folliculitis. What is the best shaving technique for a young man with HS and folliculitis?
The best shaving technique.
Yeah.
Okay. So for HS or folliculitis, okay, so folliculitis, I presume scalp folliculitis.
Mm,
So the advice usually is don't close shave because it's a close shaving and the friction that stimulates and disrupts the hair follicles at the base, and as the body's trying to repair, you develop the keloidal folliculitis on those follicle areas. So close shaving, no. So that's my advice. If you know you're prone to getting scalp folliculitis, then don't close shave. If you're going to shave, use antiseptic wash. So those some of the pictures I showed you with your dermal, octanisan, or hair scrub to help cleanse the skin. It's same as HS. You use their antiseptic creams to wash the areas to help the skin. So HS is much more to do with the apocrine sweat glands in those areas in the groin. And
mm,
it's not really about shaving, it's just deep inflammation of those sweat glands deep into the skin. And it's not the shaving. Yes, when you shave and the ingrowing hair make it worse, but it's not a problem of the ingrowing hair. It's just sometimes places where you don't have even ingrowing hair, you get HS. So
mm.
it's yeah, it can be challenging. Yeah.
No, amazing. Thank you. I think just add on to that hair removal creams can be quite useful
Yeah.
for armpits and groin areas. Well, bikini
So
pants.
avoid the friction as well.
Exactly.
Yeah.
Yeah, perfect. So what is the best treatment for cystic acne on the face?
So the best treatment for cystic acne is to get it diagnosed properly, get referred quickly,
Yeah.
and then to be considered for oral isotretinoin or oral retinoids as soon as possible. This delay referral is the challenge because The topical creams and the oral antibiotics do not respond to the cystic acne well,
Mm,
and therefore early recognition and early referral for secondary care or any community care that does isotretinoin treatment is helpful
great.
to avoid scarring.
Yeah, thank you. I think you've already answered the question about sunscreen every day as a black woman, which is you can do. It's fine. So one question on black feet health
Black
is feet health. Um,
health, okay.
oh, fine. So fine. Okay, sorry. The question is skin treatment different to treat the feet of black people?
And skin treatment. Oh,
Is it different? Yeah, is it different how you treat the skin of black people compared to other people? I don't think it
you
is,
mean
personally,
you
from my
mean
experience.
what, for like a pedicure?
I think generally, I expect when it's like, from the dryness and the the thickness of the skin. But
I
yeah,
mean, like good skin health is it
yeah,
doesn't, there's no
yeah,
difference.
yeah, yeah.
You know that your skin dries quickly. So black skin dries quickly. So you don't leave it ashy, moisturize properly. Exfoliation can cause pigmentation, hyperpigmentation. So you just be careful of things you use to scrub too much.
Mm,
You have to be gentle on your skin as well. But yeah, it's any good pedicure, moisturize, look after yourself. It's not much different, to be honest.
brilliant. Thank you. And finally, I think last question is, please explain the vitamin D black skin connection.
So the importance of vitamin D is a lot to do with it's cardiovascular, it's skin. You need the sun rays in the body to produce vitamin D. Vitamin D is helpful for a lot of people get tiredness, fatigue with low vitamin D, and the resumption is because we have heavily pigmented skin in black skin. The sun rays, we don't get a lot of sun rays, therefore we are very low in vitamin D, which is generally good for our immune system anyway. So if if you over the winter months, you don't even need to test it. Just take your vitamin D supplement. I've just said, why are you going to check it? It's going to be low anyway, so you don't see a lot of sun. So just take your vitamin D supplement, and it's good for your cardiovascular health. And it's not just because it's absorbed in the skin through the sun rays as well. It's important for that. So that's where the importance is. But immunologically, for a health look, being healthy and cardiovascular wise, vitamin D is always helpful. The issue with
Amazing.
black skin is we don't get absorbed it well because of
Yeah.
the pigmentation.
Listen, like amazing. Thanks so much. So I think that's all the questions. So I think it's for me just to say thank you again. And I hope the community has really enjoyed the session because it's been comprehensive, had a wide range of things, and I've personally enjoyed listening to you today. So thank you so much, Dr. Kwasi.
Okay.
I'm going to pass you now on to pass the facilitation on to Sam, who's going to see us out. So thank you again, Dr. Kwesi, and have a good day, everybody.
Thank you.
Hello, everyone, and thank you very much again, Dr. Kwasi and Dr. Chedu. I think we had such a wonderful session there. I learned a lot, especially about shaving and about the moles, because yeah, as you get older, you get moles. So I was starting to get a bit worried, but it's good to know that it's a natural occurrence. And yeah, I look forward to, you know, learning more by watching this video again that's on YouTube. And I'm just gonna quickly go through a few slides of what's going on here at Khan. And again, thank you very much for staying on. I know we are over the time by a few seconds or a few minutes. So we do appreciate you all staying on to just learn a bit more about, your health and what's going on here at Khan. So next week we'll be having Health Hour again. The topic is going to be released via social. So please look out for that. It's going to be happening at the same time. We're going to have a special doctor here presenting, and hopefully you get to learn more about, healthy living and keeping well during the fasting season of Ramadan. That's what the topic is going to be. So please look out for that on socials. We have the Black Healthcare Awards happening this year again. It's going to be happening in London on the 4th of July. So we want to encourage everyone that knows a healthcare professional, please go onto our website and nominate a healthcare professional that you think is, worthy of being awarded. Because, within our community, we don't always put ourselves out there to be recognized for the hard work that we're doing or for the transformational work that we're doing. across the sector. So it's important that we started this Black Healthcare Awards a few years ago just to shine a light on the community and shine a light on those pioneers that are come before us, like Dame Elizabeth and Professor Kevin Fenton, just to name a few, Professor Margaret Iqbal, just a couple of people that have, shone a light on the great work that they're doing, which have encouraged all of us to do better. So with the Black Healthcare Awards coming up soon, please go on the website, nominate someone that you think is doing amazing. There's a lot of categories on there. I'm sure there'll be someone there that comes to mind when you read a category, and it's only going to take more than a few minutes to nominate someone. So please do visit the website and nominate. Scan the QR code if you need to. We have the International Women's Day happening on the 12th of March. It's going to be happening here in Greater Manchester. We're going to be using this moment or using this day to celebrate the women in our community and the women women in general. And we're going to be focusing this year on health is wealth. That's improving the physical, emotional, spiritual, psychological, and social aspects of health. I think that's important to highlight this year. Last year, we talked about womb health in the digital era. This year, we're pushing that agenda forward by talking about health as well, because, a healthy lifestyle is the most important thing that we can have, regardless of whatever we have around us. Our health is the most important thing. That's why we all tune into these sessions every week to learn more about our health and learn more how we can improve our health for our community and ourselves and our families. So we look forward to seeing you on the 12th of March at the location is going to be confirmed soon, but look forward to seeing you. It's going to be a full day from 1 to about 8:30 p.m. and it's a free event. So all are welcome, both men, women. Please do attend and come and learn some more things about, how important your health is and to improving your wealth. We have the COVID reflection service happening on the 8th of March. This is going to be happening at Gorton, the Gorton Monastery, or the Manchester Monastery as it's mainly known as. It's going to be happening from 7 to 9 p.m. This is just a reflection service on, the things that we all experienced during COVID. And COVID was quite a particular time that, changed the landscape of the world that we live in now. We lost a lot of people within our community, as most of us were frontline workers, and, from the PPE scandals to not knowing exactly what's going on. Most people that were really affected were people vulnerable that were at the front line and vulnerable people at home. And I knew a lot of people that sadly passed during that time. So it's good that we're having a reflection service just to honor those lives and see how much growth has happened in the last 6 years and how it's brought our community together, and it's going to keep pushing us to make us stronger. And yeah, we look forward to celebrating that experience together as a whole, and reflecting and coming together in hope for what could come better in the future. So thank you very much again for listening to the Health Hour today. We want to thank the doctors, Dr. Kwasi and Dr. Chiedu, we wonderfully appreciate your time and support and dedication that you provided for the community. So make sure that everyone has a wonderful rest of your weekend, and we'll see you next week, same link, same time, and God bless.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.